Hello, everyone, and welcome to today's webinar, Kidney Cancer and Chronic Kidney Disease. Now, I'd like to introduce Lydia Lauder, National Director of Programs and Public Policy at the Kidney Foundation.
Thank you. Good morning or good afternoon to everybody, and thank you to everybody for joining us today for the Kidney Cancer and Chronic Kidney Disease webinar. Before we begin, we would like to recognise the Indigenous land that we are on. Inspired by the 94 recommendation calls to action made by the Truth and Reconciliation Commission of Canada, land acknowledgements are a necessary first step towards honouring the original occupants of a place. They also help Canadians to recognise and respect Indigenous peoples' inherent kinship beliefs when it comes to the land, especially since those beliefs were restricted for so long. I would like to acknowledge that I am located in Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. It is covered by Treaty 13, signed with the Mississaugas of the Credit, and is still home to many First Nations, Inuit, and Métis peoples. Recognising that we all work and live in various places, and that you may be joining us from a different traditional Indigenous territory, I encourage everyone to take a moment to reflect on that and acknowledge it. If you know the territory in which you are situated, I invite you to acknowledge it in the chat. The Kidney Foundation would like to thank our sponsors for this 2022 webinar series: GSK Canada, Horizon, Janssen, Otsuka, Paladin, and Takeda. Their ongoing support allows us to bring many together, like today, to have broader, bolder, and braver conversations. Today's goal is to provide you with knowledge to help you understand you are not alone, and ultimately help you feel more empowered. Nowadays, we all seem to be touched by cancer, whether we experience it personally or have a loved one living with disease. Kidney cancer may not be a common type of cancer or even a widely known type of kidney disease, but it still affects many Canadians. Like other types of kidney disease, kidney cancer symptoms are usually silent, making it hard to detect the disease initially. This webinar will provide crucial information on how to support those with kidney cancer and ways to prevent this disease in the future. Our patient partner with lived experience will discuss their journey and struggles, and our medical experts will share information about new ways to identify and treat cancer. The information shared in today's webinar is current as of today, November 29, 2022. The material shared in this presentation is not intended to be medical advice. You should speak to your doctor and care team about your own individual situation. The information is intended for a Canadian audience. Now, I'm thrilled to be able to introduce our speakers for today. Thank you so much for making the time to share this important information. Dr. Tanguay is currently Professor and Chair of Division of Urology at McGill University and holds the M. Metali and D'Israeli Chair in Neurological Sciences. He completed his residency training at McGill University and a fellowship in urologic oncology at the University of Texas, MD Anderson Cancer Center. His research interests are on the development of precision medicine in kidney cancer, with the aim to discover new strategies to detect cancer recurrence and develop novel therapeutic targets. Dr. Tanguay is the Chair of the Medical Advisory Board of Kidney Cancer Canada. Dr. Yasser undertook his doctoral and postdoc studies at the German Cancer Research Center, DKFZ, in 2012. Dr. Yasser joined the Department of Human Genetics at McGill and was appointed Group Head of the Cancer Genomics Program at McGill Genome Center. During the past decade, he has developed a transdisciplinary research program to identify, characterize, and target drivers of renal cell carcinoma progression in order to improve patient survival and disease outcomes. And last but not least, Jackie Plett. Jackie's story began when she was 10 months old, when she was diagnosed with bilateral Wilms tumor, a form of kidney cancer in children. The tumor and part of her kidneys were removed in surgery as a baby, followed by chemotherapy. Jackie survived with just 2/3 of a kidney until she was diagnosed with kidney failure as an adult. Now she relies on dialysis treatments to keep her alive. Jackie is a Kidney Foundation volunteer working to raise critical funds for research and support programs for people who live with the daily reality of kidney failure. Being involved gives her hope. Jackie, may I invite you to share your story?
My story begins when I was just 10 months old. I was a very colicky baby with an unknown cancer growing inside of me. As the months went on, I developed an extremely swollen abdomen. My parents took me to the doctor, and after many tests and many doctors, I was diagnosed with bilateral Wilms tumor, children's kidney cancer. My case was slightly abnormal, as this cancer usually only appears in children ages 3 to 5 years old. I was started on chemotherapy treatments and had a surgery. They made a large incision down my chest and abdomen, opened me right up, and removed the tumor. It filled up an entire ice cream pail and weighed almost 3 pounds. They removed one of my kidneys and 1/3 of my other kidney. I'm happy and grateful to say I survived. My entire life, I have lived with 2/3 of one kidney. I know no different. Wilms tumor is the most common diagnosed type of children's kidney cancer. Although I survived, I'm still dealing with the repercussions and effects of cancer and kidney failure in my daily life. Now at the age of 36, I require dialysis to live. I've been on dialysis for 4 years. I was first diagnosed with kidney failure in 2013 with only 50% function. Not great news for someone with just part of one kidney. I began going to Winnipeg for various appointments and follow-ups with the nephrologist. Eventually, it was inevitable. And in 2018, I started dialysis. Dialysis is needing a machine that cleans your blood 3 times a week, 4 hours at a time. Week after week, I am there, whether rain, shine, or snowstorm, with no choice. You might be thinking it keeps you alive. What's so bad about that? I can tell you right now, it's not a fun way to live. Dialysis is an exact science in itself. The main function of our kidneys is to filter out all the waste in our bodies. It then transfers to the bladder and we pee it all out. My body doesn't do that anymore, and that's why I'm on dialysis. Dialysis also removes the excess fluid for me. To make dialysis easier, you're allowed to drink 1 liter a day. That's 1,000 milliliters or 2 500 milliliter cups a day in 24 hours. That has got to be my biggest struggle, is sticking to a strict fluid intake. And eating healthy is important, such as limited salt intake, as this can also cause fluid overload. Also careful that I don't eat foods too high in potassium and phosphate. These are minerals the kidney can no longer filter out. Some might say I have an extreme and exaggerated diet. My reason is that I want to live. I want my new kidney. I want my new lease on life. Being a dialysis patient and getting involved with the Kidney Foundation has provided me with tremendous support outside of friends and family and connecting me with a community and others just like me. Donation support means the foundation can help me with gift cards for essentials like gas and groceries. It helps to relieve some of the financial pressure that living with a chronic illness has caused. As a volunteer, I help support the Kidney Walk every year, planning it alongside others and working hard to raise critical funds. These funds make research and support programs possible for people like me who live with the daily reality of kidney failure. They also provide hope. Every research study, every new treatment, every support group signals a brighter future for people with kidney diseases, kidney cancer, and kidney failure. We are working towards better healthcare options, more reliable information, and a stronger community that can help people with kidney disease thrive.
Thank you so much, Jackie. May
Thank you.
I invite Dr. Tanguy to speak, please?
Thank you very much for the invitation. It's really my pleasure to be here and participate in this webinar with the Kidney Foundation. Actually, as you see in my bio, I studied in Texas in the 90s, and at that time, actually, part of me going there was supported by a Kidney Foundation grant. So you can see that these are very important, and I cherish that support that I received throughout all these years. What I was asked to do today is just to do a very brief overview of what kidney cancer is and how we treat it in a localized or more advanced stage. Obviously, it's very superficial because of time constraint, but I'll be happy to go in any details that you would like, during the Q&A period, and please send your questions so that we can look at them. So if you look here, the what kidney cancer represent in terms of a frequency, it's more common in male. It represents 4.4% of all cancer in men and 2.3 in women. So you can see that unfortunately it's on the top of the list of cancer that we find in men and a bit lower in frequency in women. Now, we can't lump everybody together. That's one of the particularity of many of the cancer we treat, and it's the same for kidney cancer. So we've heard, Jackie's story with Wilms cancer, which is really a cancer that we see in infant more than in adults. But you can see here that in adult cancer that we treat, there's different type of cancer. The most common is what we call the clear cell carcinoma or the conventional kidney cancer. And all of these subtlety between the different cancer are very important to us because they originate from different part of the kidney. The target in terms of treatment will be different, and this is an information that we need to obtain when we diagnose someone with kidney cancer to understand how to best treat them. Kidney cancer represent in Canada close to 8,000 new cases per year. What's interesting for kidney cancer is that the frequency or the number of patients affected with this disease is growing every year for the last 20 years. So it's not a cancer where we have a stable number of patients affected. Every year there's more and more. We looked at the frequency of how it happened. This is a cancer that's more common in the 60s and 70s, but I must say that nowadays we find it in all age group, and we see that patients referred to us in their 20s with kidney cancer, as well as in the more elderly. It's most common in men than in women, and you can see here that the extent of the disease at the time of diagnosis is variable. One thing we have seen is that a lot of these cancer are picked up more early than before. If you look 20 years ago, the patient presented and at least a third of them were already metastatic, meaning that they had spread to other organs. It's not the case anymore. In Canada, we have a registry that follow our patients with kidney cancer. And from that registry, it's about 15% of our patients that present in a more advanced form, which is a great thing. Now, how do they present? I would say that today, the most common presentation, it's what we would call an incidental finding. People go to their physician for all kind of other complaints. They think they have a gallstone, they have low abdominal pain, they get an ultrasound or a scan, and boom, we find a mass in the kidney. So this represents probably 60% of the patients we see today. The beauty of this is that we find them much earlier than in the past, as I just mentioned. And so the earlier we find kidney cancer, the more likely we are to cure the disease. For those that they present with symptoms, the number one presentation, it's blood in the urine. You see these big billboard about bladder cancer Canada, where they see the lemon that are all yellow except one that's red for the blood in the urine for the presentation of bladder cancer. It is exactly the same for kidney cancer. That's the most common way of presenting. And then we have like less specific symptoms like pain, some discomfort, some weight loss, weakness, anemia, all very non-specific symptoms that lead to more tests and then finding of the cancer. If we suspect kidney cancer, or if we have an ultrasound that sees a mass in the kidney, what we do initially is we do some imaging. We do some X-ray, classically CT scan or MRI, to look at the abdomen and the chest to identify if truly there is a mass. Then we do some laboratory evaluation, some blood tests. Unfortunately for kidney cancer, we don't have a blood test yet that allows us to determine with certainty that someone has kidney cancer. What we see on the blood test is more the downstream impact of the development of cancer that may affect blood parameters, but the blood test itself would not be associated with kidney cancer. Then we do what we call staging. The staging is really to look at the extent of the disease. How big is the mass? Does the mass has grown outside of the kidney? As it spread to other organ? And we often refer to stage 1, 2, 3, 4. Or another way to look at it is what we call the TNM staging. The TNM, T is for tumor, N is for lymph node, and M is for metastasis. And using this system, your physician will understand clearly how extensive is the disease. And based on that, that's how we determine how we're going to treat the patients. There are two types of staging. There's what we call clinical staging and pathological staging. The distinction is important because clinical staging is at the presentation. When you arrive, we do your X-ray, we look at it. This is the clinical staging. If we remove your kidney and we do biopsies and we look at it under the microscope, that's when we call pathological staging. The pathological staging is obviously more accurate because we had the chance to look in more detail into the disease itself. The second information we get is the grade. So we have the stage for the extent. The grade, look at how aggressive the cancer is. So we have grade 1 to 4. This is the aggressivity level. So often when you discuss with your physician about a new diagnosis, we look at the staging and the grade. These are two important information that you should always leave the office of your urologist or oncologist knowing what it represents for you. Presentation, you can see here in blue that represent what we call stage 1, so localized disease. You can see that it represents probably 60 and up, sometimes up to 70% of our patients have a localized disease. As I mentioned before, often it's because it's picked up incidentally looking at other things. Now, often we confirm the diagnosis of cancer with a biopsy. Is that true for kidney cancer? Yes and no. We don't always do a biopsy because often if you have a mass that's solid in your kidney, the odds that it's cancer, it's very high. And depending on your age and the decision of treatment we're going to make, sometimes we're going to do a biopsy to confirm what we're dealing with, and sometimes we will not. Certainly, if you present with the kidney cancer that seems to have spread to other organ, we will always do a biopsy. One, to confirm the disease, and the second is to determine what type of kidney cancer you have, because the treatment will be very different from one to the other. So that would be an information that's done. When we need a biopsy, it's classically done by the radiologist with a needle where they take a sample of your kidney tumor and then it's looked under the microscope and we can determine what type of kidney cancer you have. Let's talk first for those who present with a cancer that's localized to their kidney. There's a number of options available to you. The first one you're going to look, it sounds funny, but it's to observe. You know, why would we observe? We know that kidney cancer, when they're picked up early, and often we have patients referred to us with a 1 centimeter tumor in their kidney, we know that these grow extremely slow. They have a very low risk of spreading. And for many patients that are elderly, that have other health issues, observation is a very good option and may delay or avoid treatment in many of them. So in our Canadian guidelines, actually, if you have a mass of 2 centimeters or less, observation is the #1 option that we offer our patients. So not to be worried about that. One thing that we do very often when we choose observation is we obtain a biopsy, 1, to confirm the diagnosis, and 2, to make sure you don't have the rare variant of more aggressive kidney cancer where observation may not be as indicated. We've heard that if you lose part of your kidney, you know, from Jackie, that you may end up in dialysis later on in life. So that's always something that we, take a great precaution of. We try to preserve as much of the kidney as possible. So partial nephrectomy is the removal of only part of your kidney. The goal of this is to remove the tumor and to preserve the kidney function. I think that's very important. We know that if you select patients well, whether you remove the entire kidney or just part of the kidney, the result in terms of cancer care or cure of the cancer is the same. So we always try, when possible, to preserve the kidney. And that can be done multiple ways. It can be done by open surgery or the conventional surgery. It can be done with laparoscopy, where we have these little entry sites, and the surgeons hold the instrument, and we look on the camera to do our surgery. Or more recently, we can do that with what we call robotic assisted surgery. Basically, it's a form of laparoscopy where a robot holds the instruments and the surgeon sits in a corner and manipulate the robot, and it has multiple advantages to do it that way. So Many centers in Canada have robotic surgery as an option to offer their patients. Then if the mass is small, we can also destroy it by thermal ablation. Thermal ablation is basically you can destroy it by either heating it or freezing it. And this is a good option when the mass is very small, ideally less than 3 centimeter and optimally less than 2 centimeter. You can see here that's what we call radiofrequency ablation. It's like a little umbrella, and you can puncture into the tumor. You see at the lower panel, and deploy this umbrella inside of the tumor, and then you put the electric current inside of it that will heat the tumor and destroy it by the heat. The other option that's very often used also, it's what we call cryotherapy. It's the opposite. We destroy the tumor by freezing it. We create basically an ice ball that include the entire tumor, and by freezing it, the cells will be destroyed, and you're going to be able to destroy the cancer. So there's advantage and disadvantage to everything we do, and then we can look at what's best for our patients. For tumors that are larger, we can do what's called radical nephrectomy. In this case, we would remove the entire kidney. Classically, it's used for patients that have larger tumor where we cannot save part of the kidney, and then the entire kidney will be removed. And we always make sure that the other kidney is good enough to support, the function on long term. But that would be something for larger tumor. You can see here that kidney cancer is a cancer that have specific characteristics where the tumor can extend inside of the main vein in our body, and sometimes we need like larger surgery to be able to remove completely this tumor. Now, how do we predict after we remove the cancer the chance of coming back? Well, we go back to what we discussed earlier: the stage, the grade, the type of kidney cancer it is, its size, if the patient had symptoms at the beginning, and gender. Unfortunately, we know that men with kidney cancer don't do as well as women, for example. So all of these are put into account. And based on that, if we remove all the cancer by surgery or by ablation, then we will have a strategy of following these patients according to the risk of coming back with scans and ultrasound throughout the years to come after. Unfortunately, kidney cancer is not always a cancer that's localized. It has a chance to spread, as we've seen. These are the area in the body where kidney cancer can spread, which is basically everywhere, but the most common being the lung, the bone, the lymph node, and the liver. These are the most common organ affected for kidney cancer when it spreads. Treatment for those is very varied. Sometimes we can treat by surgery when it's very limited, but most of the time we're going to use what we call a medical treatment. In kidney cancer, we don't use chemotherapy. It's something that has never shown a great benefit in kidney cancer. It's a strategy that we have not done. But kidney cancer, like melanoma, the skin cancer, for years has been shown to be one of the cancer that was responsive to what we call immunotherapy. Immunotherapy is a treatment where we boost your immune system to destroy cancer cells. And in the past, we had treatment like interferon and interleukin-2 that today have been replaced by more effective treatment. What revolutionized the treatment of kidney cancer is the arrival of what we call targeted treatment. Targeted treatment are molecules that we could give the patient that would, for example, starve the blood vessel development inside of the tumor and allow the tumor to shrink. And a number of drugs like these mentioned here came along on the market and had a great impact on our patients and replaced the old immunotherapy we were using. Until recently, where immunotherapy had a comeback in multiple treatment of cancer, not just kidney cancer, but there's two researchers through their research found two molecules that can help, boost the immune system. Actually, they won Nobel Prize a few years ago for this finding, and this basically either used alone or in combination with targeted therapy has revolutionized the treatment of kidney cancer and has certainly made a great comeback for our patients to help, treat more effectively their kidney cancer. When we decide about the treatment, there are factors that we use to determine the risk of responding to our treatment, and the how more aggressive or more favorable the cancer is. And this is, for example, one of the strategy that we use that was developed by a researcher in Calgary, in Canada, that's used worldwide now. So to wrap up, I would say that in kidney cancer, there's been great improvement at all levels. I think we have learned to reduce the morbidity, the downside of our surgical treatment through the innovation in different surgical technique. There's also been major improvement in the treatment of more advanced disease or disease that has spread to other organs. But as you can understand, there's always room for improvement, and that's why Kidney Foundation is there to help support kidney cancer research. And it's very important, to improve the outcome of our treatment and the quality of life that we can offer to our patients. So I think I'm going to stop here and pass this to Dr. Riaz Al-Hosseini to discuss kidney cancer research.
Thank you very much. I thank Kidney Foundation organizers for inviting me to this presentation. It's an honor to be here and share our research with people who are interested in knowing what we do. I'm based at McGill University, where Dr. Tange also is practicing at the clinical side. And at the McGill Genome Center, where my laboratory is located, we have started a research program with the objectives of developing new methods using genomic information that may be helpful for clinical application, specifically for prognosis purposes, for example, predicting the outcome, or for also predicting the response to therapies. For today's presentation, I'm going to share with you one story that is about a research stream that we have been following in the past, actually decade. We started in 2012, and as of yesterday, it was actually accepted for publication in a journal called Clinical Cancer Research. And the goal was there to identify genetic biomarkers that hopefully can be used in the clinics for risk assessment for patients after their curative surgery. So this research actually was supported also by Kidney Foundation of Canada in the past couple of years. So to start my presentation, I would like to show you this, let's say, background slide. As Dr. Tange mentioned, patients who come to the clinic with kidney cancer, either they are affected by localized disease, where the tumors are having the stage 1 to 3, or they have disease that are already metastasized. So I'm going to focus my presentation on patients that have localized disease, because that's the research program that I would like to discuss with you. Usually these patients are treated by curative surgery, where their tumors are removed, or other type of treatment, as you heard from Dr. Tange, and then they are sent home. But about 30 to 40% of these patients actually develop recurrence or experience metastasis in the coming years. And there is at the moment no biomarker to identify these patients and to actually stratify them based on the risk of relapse. So our goal here was to see whether we can use information about genes and abnormalities that we see in the genes in tumors, to use them to develop some methods that can help, hopefully, clinicians to identify these patients that may have more aggressive tumors. So currently, as Dr. Tange again explained, the risk assessment or prognosis is mainly done based on looking at the tumor clinical evaluation as well as pathological evaluation, where they are this microscopic examination where trained pathologists look at tumors as you heard, there are different type of kidney cancers. Let's focus on the more aggressive one and more frequent one, which is clear cell subtype. And they look to the morphology of these tumors under microscope, and then they predict the outcome. So it turns out that these methods have been very helpful, and they have helped a lot to identify patients with aggressive disease. But still, there are some patients whose tumors look similar under microscope, but they show different outcome. For example, they develop recurrence or metastasis. Some of them they do, some of them they don't. And then our hypothesis was that these tumors may have some biological differences that cannot be captured by microscopic examination, and they need to have something with more resolution, some examinations with more resolution that are really submicroscopic. And that is why we started to look at genomic information in the tumors. Just one background slide for you to introduce you to genomic for those who may not be familiar with the field. So within a cell, we have the core of the cell called nucleus, where our genetic material is stored in form of chromosomes. And these chromosomes are made from molecules called DNA, and these DNA molecules actually include the genes. Genes are sitting there. In a normal condition, in a normal cell, these genes have codes that used by cells to introduce proteins, and these proteins are functioning in the cells to actually process the normal activities of cells. When a gene is damaged, and we call this damage a mutation, when a gene is mutated, the result can be an abnormal protein. It produces an abnormal protein, or it may not produce any protein. Therefore, the function of cells will be actually hampered, and a cell cannot do the right function. So in kidney cancers, we see these genetic mutations quite often, and we hypothesize that perhaps we can look at these genetic mutations, identify them, and look if they can tell us, if their presence, for example, in a tumor can tell us this tumor may have aggressive biology. So this is a study that I was involved called kidney cancer, called CAGE-KID, which is cancer genomics of the kidney. This was a very large study involving 9 countries, and number of patients who participated was close to 1,000 patients, where we started our journey into with the genomics of kidney cancer, because we needed to first understand how genetic mutations look like in kidney cancer cells. So the study had 3 phases. In the phase 1 of the study, we looked at whole human genes. So we have about 20,000 genes in a human cell. We looked at all of them to identify those genes that have mutations, that have abnormalities. And they have these mutations not only in one tumor, in multiple tumors from multiple different patients, because we believe that if a gene is important for a tumor cell, for a tumor to grow and to actually be aggressive, it should be found in multiple patients. So, and in the second phase of the study, we focus on 42 genes that showed this pattern and were potentially important in kidney cancer development or progression. And we studied them in additional patients, this time about 400 patients that contributed to this study. We actually look at these genes in their tumors and then analyzed our data. And finally, we selected 12 genes and developed an RCC, or renal cell carcinoma gene panel. And we believe that these 12 genes have the potential to help us to identify biomarkers that can predict outcome of the disease. And then we again study these 12 genes in additional about 500 patients. So here I'm going to show you some results, and here we looked at status of these genes being mutated or not being mutated, and a connection, a link between these patterns and patient outcome, disease outcome, sorry, specifically disease-free survival, time to develop recurrence or metastasis after they were treated with curative surgery, after their tumors was removed or their kidney was removed. And here I'm showing you a curve called Kaplan-Meier curve. What you see here at the bottom in the x-axis, you see years, 5 years, for example, here after surgery. And on the y-axis, you see the status of being developing, chance of developing metastasis or risk of developing metastasis or recurrence. So using the genetic information of these 12 genes, we identify 4 groups of patients that are actually shown here by different colors. And on the right side, I have this legend for you. We call them VHL plus 0 until VHL plus or more than 3. So it means that VHL is a name of a gene, which we know that is a very important gene in development of clear cell subtype of kidney cancer. We identified that if the VHL alone is mutated and there is no other mutations in the 12 genes that we screened, these patients are called VHL plus 0. And then if there is a tumor, there is a mutation in VHL in a tumor, and there is one more additional genes that have mutation, we call them VHL plus 1, and so on. And we realized that these groups of patients show different risk of disease recurrence. For example, if we draw a line at year 3, we see that in the first group shown on top, VHL plus 0, if we look at this group, we see at year 3, the risk of having a disease-free survival, having no metastasis, the chance of having no metastasis is about maybe 90%. These patients have the chance of having no metastasis, live without any recurrence at year 3 without at 90%. But at the same time, if we look at year 3, patients that are grouped in VHL plus 3, they have only about maybe 55 to 60% of a chance that having a disease-free survival. So this showed us that this genetic information actually can be very helpful to identify patients with different risk of recurrence and metastasis. So now, Dr. Tange mentioned to you that at the moment in the clinic, there are factors that are used for this risk assessment, including the stage. We actually examined whether if we look at a specific stage, only look at patients whose tumors belong, for example, to stage 3, does this genetic classifier still help to actually improve risk assessment for these patients? And that is what I'm showing you here on the right side of the slide. If we again draw a line at year 3, we clearly see that all those patients whose tumors are of stage 3, but their genetic classification is VHL plus 3, have disease-free survival of perhaps 30% or 35%, whereas patients with, again, tumors of stage 3, but genetic group of VHL plus 0 have a much higher chance of disease-free survival. So this research actually helped us to think of developing a genetic-based tool that hopefully can improve a risk assessment in the clinic. And that is our vision. This slide shows our vision. That is what we are working actually with Dr. Tange to examine its potential for clinical application. We think that if we can do this genetic test analysis on the tumors parallel to pathology analysis, then we can ask this question whether a tumor that is removed from a patient has those, let's say, genetic information that are associated with poor survival. If yes, perhaps this patient has higher risk of recurrence. And what can be done? Perhaps the follow-up of these patients can be personalized based on this information to have a more frequent follow-up imaging test, or even earlier introduction of therapies to avoid metastasis, or to actually manage it earlier. And if there is no genetic information that is linked to poor survival, perhaps the patient can have a less stressful follow-up strategy and experience improved quality of life. So, of course, this is at the moment at the let's say still research level, and what we think may help actually to bring this research to the clinic is to make it more accessible and more and less invasive for clinical application. What we see is that, and this is what again we are working on with Dr. Tange, is to actually use liquid biopsy strategies for this genetic test. At the moment, what we do is that we are comparing the outcome of this genetic classifier in samples that we receive from patients in both their tumors as well as in their blood that they donate, to see whether we can actually optimize and we can establish this genetic classifier based on information that we can get from blood of patients rather in tumors. That hopefully give us a chance to expand the application of these tests to patients whose tumors may not be accessible or may not be large enough for genetic analysis. So I would like to finish my presentation by acknowledging people who really helped with this study. The KHKIT Consortium, there are many clinicians and basic scientists who contributed to this project. I have just listed their name here. And in my lab, I would like to highlight two persons, Madeline Arsenal and Kate Glennon, who have been working very passionately on this project, and I'm happy to see that the results are actually there. And also at the Genome Center, our colleague Antoine Paccard, and also Dr. Tange's team and his colleagues at McGill University, who help us with the clinical question and clinical insights. Thank you very much. I'm happy to take any question that you may have.
Thank you so very much to our panelists today. So we've had a couple of questions submitted earlier, but we have one live that I would like to present to, I guess all three panelists might be able to answer this one. Does kidney cancer run in families?
Maybe I can take this one. So the answer to that is yes. So we have families that are affected by genetic disorders that will increase their risk to develop kidney cancer. These are rare disorders, but for those families, very important to be aware of. And when families are affected by these genetic disorders, then we have very specific follow-up guidelines and treatment for them, because some of them will develop multiple and bilateral kidney cancer. In our practice, the question is, when do we check for that? Because everybody that face cancer want to make sure that their family and loved one are protected, and it's not something that they transmitted to their, to their children. So we have in Canada very specific guidelines on when do we test for genetic disorder. So classically, the younger patients in, below the age of 45 or 50, patients that have tumor in both kidneys, patients that have multiple tumors, or patients that have rare form of kidney cancer. These, we send them to the medical genetic team. They will meet a counselor that will meet with them, look at the history of the family, and then they will determine together if a genetic testing should be done or not. And nowadays, compared to before, it's very easy to do these genetic tests. So we can do that and then reassure if there's nothing found, or if something is found, then we can go and look at the entire family and see who's affected by this disorder.
Okay, thank you very much, Dr. Tanguy. And once again, Dr. Tanguy, I have a question for you. You mentioned in your presentation a few times that more men than women tend to have kidney cancer. Is there a reason for this? Why is it that more men would have kidney cancer than women?
Today, we don't know. We don't know why. I think it's probably something that we'll elucidate, in the future. We know also that the behavior, as I mentioned, is a bit different in men and women. It's not a guarantee of less aggressive disease in women, but certainly we know that there's a difference like that. Yeah.
Okay, thank you.
The exact cause is not known.
That's great. Thank you very much. And Dr. Yasser, you certainly did provide hope to a lot of people by sharing your research and hope in being able to identify kidney cancer. I have a question. You were talking about how these tests are now being done in the lab. What would it take to bring it to the bedside or to patients in real time?
What I can say is that the results are very promising at the moment, but for clinical application, we need more than promising. We need really results that are solid and robust. So in our side, what we think we should do is that we make sure that these results are solid in additional, let's say, studies, maybe even independent studies. That is what we are trying to develop with the help of Dr. Tanguy to expand this analysis and include this type of project in a pan-Canadian initiative with colleagues from Toronto, for example, colleagues from BC, to make sure that in different centers, similar results are obtained. And we can help, again, from technological side of it, to help to develop laboratory tests that can be used in the clinic. And then I think providing these robust results and tools, hopefully it opens the way. But at the same time, I also believe that it's very important that clinicians decide where this can be helpful, because we are not going to decide about how these results can be used. And it's important for them to, decide and tell us how we can help.
Thank you very much for that, Dr. Yasser. Oh, sorry, did I interrupt somebody then? No, okay. And we're finding also that kidney cancer has been picked up earlier than before, but there still isn't any blood test for a specific kidney cancer test at the moment. Is there hope for one in the future?
Well, I think we have to be hopeful, that the research will lead to something that allows us to diagnose earlier. And I think that's the dream of every cancer. There's just a few of the cancer that have the luxury of having a blood test. And even for those that have it, there's a lot of controversy on the use and how to apply it. And do we diagnose too many patients? Prostate cancer for urologists is a good example, where we have a blood test that is helpful to diagnose earlier cancer, but its use create also a lot of questions and concerns. So that's always the hope that research will bring us there. We know that imaging, because as I mentioned before, through X-ray, ultrasound, scans, we diagnose these mass in the kidney. For those where it's found, it's extremely valuable, and they're very happy to have had that test. But it's not a test that we can expand to everybody. For example, if we decide that everybody should get an ultrasound at age 50, you can imagine the strain that it places on our system, right? So finding a blood test that allows us to diagnose earlier is certainly a great dream for any clinician and researcher. Well, we don't have that yet.
Thank you very much for clarifying that. It certainly does bring hope, though. And Jackie, I'm now going to focus on you here. Thank you so much for sharing your story earlier. It was
Thank
really
you.
brave of you to come and speak about your experiences today. And I guess after speaking, hearing Dr. Tungay speak and Dr. Yasser speak, I guess from a patient's perspective, how does this make you feel? Does it provide you with a sense of hope, particularly with being a cancer patient and a chronic kidney disease patient?
It does. It provides a lot of hope to know that there is great research out there, doctors who know what they're doing. Yeah, it's amazing.
Thanks so much, Jackie. Are there any other questions at this stage? Just looking at the team to see if there's anything in the back end. Well, seeing there are no more questions at the moment, I would really like to sincerely thank our presenters today. It has been such a pleasure to have you today, and I feel very honoured to have you present your work and provide an overview of kidney cancer, and also Jackie for sharing your story today.
Thank you for having me.
If there are any questions in the future, please do not hesitate to reach out to us. We're just sharing a few resources that could be of benefit to you. We're committed to providing information and educational resources about kidneys and kidney disease. We invite you to visit our Kidney Community Kitchen for recipes, information and tools to help you manage a kidney diet if you're on a kidney diet. Through our regional branch offices, we offer advice and support about accessing services within the healthcare system, assisting people to access other supports in their community, and offering assistance in skills for self-advocacy. We invite you to contact us if you have any further questions, or to speak to someone in your community, or to access further educational materials and resources.
Thank you everyone for attending this webinar, Kidney Cancer and Chronic Kidney Disease. On behalf of the Kidney Foundation of Canada, thank you for joining us today. Stay well and enjoy the rest of your day.